A 7-year-old boy. A 7-year-old boy presents with head turn and unsteady eyes. Nystagmus has been noted early in life. He has turned his head to the left side since he was able to sit up. The nystagmus and head turn have been stable over time with no eye misalignment noted. The head turn has been interfering with his normal function.
Okay, Dr. Khadija. First of all, Assalamu alaikum. Today, inshallah, we will start our lecture number 4, and we will talk about congenital nystagmus. Here, he is a child, 7 years old, and he came with head turn and unsteady eyes. So he has nystagmus. And the case mentioned that it starts in early life. Okay, and he turned his head to the left side as mentioned here in the paragraph, and you can see it here in the picture. Okay, and when he just turned his head, the nystagmus become more stable with no misalignment. Dr. Muhammad, do you want to add anything before we go to the examination?
No, no, no.
Okay.
Continue.
Dr. Khadija, please continue.
Examination. Visual acuity without correction. In the right is 20/25 and in the left is 20/30. Cycloplegic refraction. In the right is plus 0.75 severe and in the left is plus 0.75 plus 0.5 into 100 degrees axis. External examination. Marked head turn to the left approximately 45 degrees. The head position remains stable throughout the course of the examination. Sensoromotor evaluation, motility. Ductions and versions were full. Conjugate small amplitude high frequency horizontal jerk nystagmus, that is right beating in right gaze and left beating in left gaze. The amplitude increases in left gaze and it decreases in right gaze. Relative null point. The intensity also decreases in up gaze and down gaze, but not as profoundly as in right gaze. The nystagmus is partially damped at near with convergence and at distance with base in prism. Deviations. For distance uncorrected is ortho and for near uncorrected is also ortho. Stereopsis is 50 arc seconds. Slit lamp examination, no iris transillumination defects noted. Dilated fundus examination, well-formed foveal reflexes, normal appearing optic discs with no optic nerve hypoplasia.
Okay, before we go to the assessment, first of all, here they talk about motility, and there is a lot of characteristic points about congenital nystagmus here. Dr. Muhammad, do you want to comment, please, here?
Yes, yes. When you describing the nystagmus, you should mention a lot of things. You should mention this is a conjugate nystagmus, conjugate movement, or inconjugate movement. And also you should mention the amplitude. The amplitude means here uh, the length of the nystagmus. It's small, it's medium, it's large. So here it's a characteristic of this nystagmus is small amplitude. And another thing, the frequency, the fast of the nystagmus is very is high, is slow. So the frequency here is very specific sometimes to specific types of nystagmus. It's also here you should mention if it's uniplanar or multiplanar. And also should mention if it's horizontal, vertical, seesaw, a lot of things. So, and also you should mention the null point if there is also a null point. Sometimes you cannot find a null point. And also you should mention if this nystagmus decreases or increases by some things, like some kinds of nystagmus decreases by convergence. Some kinds of nystagmus increases with fixation. some kind of nystagmus increases in some gazes, like right gazes or left gazes or up or down. So it's a lot of these things should be mentioned in the characteristic of nystagmus. This is the first thing. The another thing, sometimes of nystagmus associated with with squint, sometimes with esotropia, exotropia, like this. Another thing, you should also mention the extraocular motility. It's a free, or it's if there is a limitation in extraocular motility. So all of things should be mentioned, and the other thing, the vision, because of congenital motor nystagmus, sometimes almost the vision in congenital motor nystagmus is very good. It's better than 612. But the other forms of nystagmus, especially congenital sensory nystagmus, the vision almost very poor.
Yes, thank you. I just want to add here some points. So here, when they talk about motility, mostly they characteristic all of the finding in congenital nystagmus. First of all, the amplitude, mostly it's small, and the type of nystagmus, mostly also it's jerky nystagmus. It can come pendular, but it's not common. Mostly it's jerky.
If please share with other audience what the difference between jerk and pendular. I forget it. I
Uh,
forget to mention jerk. It means that there is a fast and slow phase of nystagmus, and the pendular, the fast and the slow phase is equal. There is no slow or fast phase in pendular type of nystagmus. And in nystagmus, when we say right nystagmus, we means that right الفاست phase of this nystagmus in the right gaze.
yes, you are right. And the other things, the congenital nystagmus, always it has a null point, and always, or in most of the cases, as I know and I see, the nystagmus, it will decrease in convergence. So when you tell him to focus on a near object, you will see the nystagmus, it decrease. This is one of the important signs. The other thing, it decrease in sleeping. So this type of nystagmus, when he sleep, it decrease. Okay, these some points about congenital nystagmus. It can help you to recognize it. And mostly, or all of the cases that I saw, they are horizontal. So you will see in the horizontal midline of this patient. Okay, Dr. Khadija, please continue the assessment and plan.
Dr. Hunter's assessment plan. This patient has congenital nystagmus with no strabismus, good binocular vision, and no detectable structural abnormalities causing reduced vision. It is common for the severity of nystagmus to vary with gaze positions. The location where the movements are least severe is known as the null point. And when the null point is away from the primary position, significant symptoms can result. Patients will typically adopt head posture turns in order to shift the eyes into position from the null point, and severe head turns can cause a host of problems for the patient, ranging from limited motility or chronic neck or back problems over time. Our patient has to turn his head far to the left in order to find the null point in extreme right gaze. This condition is commonly treated with what is generally known as the Kestenbaum-Anderson procedure, or Kestenbaum procedure for short. The goal of the surgery is to shift the eyes in the direction of the head so that the null position will be as close to primary position as possible. In this patient, the head turn is to the left, so I want to move the eyes to the left. The exact surgical dosage for the procedure vary. My surgical table for nystagmus is in Appendix 3. To avoid any confusion when using the table, I configured the numbers in the form of two separate tables for head turn right versus left. That way, on the day of surgery, there is no need to refigure which muscles are pressed and resected. In this case, the patient has a turn of 45 degrees or more, so I will choose the maximum surgical numbers in the table. This can be expected to have the side effect of reducing eye movements in the direction of the large recessions. In this case, it should limit movement of the eyes to the right. Since there is so much surgery to perform in a single setting, I find it very helpful to write out the 4 procedures with a dark marker on a large sheet of paper and post this page at the head of the bed before scrubbing in. I have also found that with 4 muscles and 2 large resections, this procedure creates more discomfort than typical strabismus surgery in a child. And I warn families that the child may experience significant discomfort for up to a week after surgery.
Okay,
Visual
Dr. Muhammad, do you want to comment here for the first paragraph about his plan of surgery?
It's a very famous procedure, kestenbaum procedure in nystagmus. Here, the rule says you should move the eyes toward the direction of the head turn. So the head turn here, I think, in the left. So you should move in the left, yes. So you should move the eyes toward the left. So we should make a weakening procedure for the right lateral rectus and strengthening muscle, strengthening procedure of the right medial rectus, inversely in the left eye.
Yes.
With some consideration about the degree of the first turn, you can use the tables. You can find it in American Academy, or also here, also in the Kenneth Wright. You can find it easily in any book.
So he tried to move the both eyes toward the null point, so the nystagmus will decrease and the head turn
Not
also.
not the null point.
Yes.
Here's the goal is to move the null point from the right gaze to the primary position
Okay.
by
So he
moving
by moving the eyes. Mhm.
the eyes toward head turn. So when the patient awake from the anesthesia, the null point, it should be shifted from the right gaze toward the primary position.
Okay, this is now very easy and perfect explanation. So this patient, he has null point when he just make lifting or just tilting his face to the left side. So I want to change this null point to the primary position. So his head tilt, it will become in the primary position. So this is why he shift both eyes to the left side. So here, just to to just summarize it, he will resection the medial rectus of the right eye, recession of the lateral rectus of the right eye, so he will move his right eye toward the left side. For the left eye, he will resect the lateral rectus and he will recession the medial rectus. I hope it become more clear now. Yes, Dr. Khadija, please continue.
Visual acuity tends to be better at near in congenital nystagmus, and in some patients, the nystagmus may become imperceptible with convergence. The oscillation is said to damp with convergence. This observation inspired the idea of divergence surgery to improve visual acuity in nystagmus. By performing bilateral medial rectus recessions on an orthoptic patient with excellent stereoacuity, whose nystagmus dampens with convergence, the convergence state is required even for distance viewing. With the corresponding reduction in the severity of nystagmus, this treatment is known as artificial divergence surgery. Patients are generally given a trial of base-in prisms to stimulate the results of divergence surgery. Though I have also used late suture adjustment as a precaution in the event that an inappropriate candidate cannot tolerate the required convergence, I will combine artificial divergence surgery with the kestenbaum procedure in some cases. In this patient, the head turn is severe and the surgical doses are large. Binocular vision is good, but not excellent, and the nystagmus only partially dampens with convergence. So it is not worth the risk of causing an exotropia to gain the benefits of artificial divergence.
Let me ask you, Dr. Muhammad, do you have any experience about this artificial divergence surgery? And did you believe?
No, no, I believe it.
Yes.
Yes, because most of patients with congenital motor nystagmus, because of nystagmus is dampened by convergence, the vision at near is very good rather than at far. Here, the doctor or the author mentioned that he make a recession for the medial rectus to strengthening the divergence here.
And it's work when he just make bilateral medial rectus recession.
I don't know.
Hmm.
Uh, uh, Actually, it should works. It should works.
Okay. 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 Continue, Khadija. Surgery.
Surgery. The Kestenbaum-Anderson procedure was performed using the hangback approach for the recessions. For resections, my preference is to resect an extra 1 millimeter and then allow the muscle to hang back 1 millimeter so that the red muscle fibers are less visible where they would otherwise replace the white tendon fibers at the original insertion. This reduces the mild cosmetic deformity that results when muscle rather than tendon extends all the way up to the original insertion and is visible under the conjunctiva. In this case, I resected the extra 1 millimeter on the right medial rectus muscle, but on the left lateral rectus muscle, the technical difficulty of resecting more than 11.25 millimeter precluded this extra step.
Continue.
Follow up at the
Uh,
2-month
Procedure summary.
procedure summary. Recess right lateral rectus 9.75 millimeter. Resect right medial rectus 8.5 millimeter. Recess left medial rectus 7 millimeter. Resect left lateral rectus 11.25 millimeter. Adjustable sutures were not used. Follow up. At the 2-month follow up visit, the family reported that the head turn markedly improved right after the surgery. His overall function also appeared to be much better with improved throwing and catching. The patient stated that he could see better. Visual acuity without correction in the right is 20/30 and in the left is also 20/30. External examination, residual head turn to the left of 5 degrees at distance, no head turn at near. Sensoromotor evaluation, motility. There is a high frequency, low amplitude horizontal jerk nystagmus. No limitations of ductions is appreciated even in right case. Motility photographs were not obtained. And deviations use ortho for distance and near. Stereopsis is again 50 arc seconds. Additional follow-up at the most recent postoperative visit, 3 years after surgery, the examination was stable with 20/25 corrected visual acuity in each eye and a persistent residual head turn of about 5 degrees. Ductions and versions remained full.
Okay, before we go to the review, Dr. Muhammad, look at the number here. He said resect left lateral rectus 11.25, and it's big numbers. What did you think?
Uh, as I mentioned before, we follow the tables. We follow the tables regarding the degree of the first term. If the first term more than 45 degree, I think these numbers is very good.
Okay. Do you
Another
have?
thing,
Yes.
I have a question to the audience.
Mhm.
If you have patient with congenital motor nystagmus, and this patient has two null points, null point at the right gaze and null point at the left gaze. So you think it should here better to procedure Kestenbaum procedure here, or weight, or prism, anything? Anyone answer this question? Again, patient.
Actually, if there is two null point, one at the right and one in the left, so the patient he is, I think, he will be in the primary position most of the time. I'm not sure.
It should.
It should, yes.
It should be null point at the sometimes at the right, sometimes at the left. Not at primary position. Sometimes at the
Okay.
right, sometimes at the left.
So you should make a procedure to make him at the primary position. This
No,
is our goal. No.
no.
Okay.
The one of contraindication to do the Kestenbaum procedure here, this is the form of the congenital, the form of congenital motor nystagmus. The two null points, one of them at the right and one of them at the left, because if you shift the null point from side to side, you will decrease the other point of the nystagmus. So it's a contraindication to do procedure when you have two null points.
Okay.
This is the first question. The second question, do you think congenital motor nystagmus patients, most of them will have like neurologically symptoms in central nervous system, or sometimes it should have an ocular manifestation like retinal dystrophy, cataract, like this?
I think it's not common.
Not common at all.
Yes.
It's a healthy patient. It's with very good vision. Central nervous system, most of them should be normal, and also an ocular manifestation here should be free. So you should differentiate congenital motor nystagmus from congenital sensory nystagmus.
Okay. So
Another
how?
thing,
Yes.
another thing. Anyone hear about the convergence blockage syndrome? This is form of congenital motor nystagmus. Congenital convergence blockage syndrome is the form of congenital motor nystagmus with esotropia. Here, because of the congenital motor nystagmus decreases with convergence, this patient select the convergence here, a convergence position, to decrease the amplitude and the frequency of the nystagmus. So the patient should present to our clinic with an esotropia, a very large esotropia. And also, when you try to measure this type of squint, the squint will increase aberrantly.
Okay.
Okay. If you think this type of a squint should measured like by Hirschberg, like 45 degree, 45 prism diopter. When you try to measure it by prism, you find yourself like measure 90 degree, because this patient, this type of nystagmus increases with convergence. And also there is also here a term, eaten up prism. This is characteristic of convergence blockage syndrome.
So you mean when you try to measure this squint, the angle, it will be not very clear, and it
It
will be
increases when you,
increases with the
yes,
prism. Okay. And the
because
nystagmus, it will also increase with the angle.
no,
Okay.
the nystagmus increases at any movement or at any point of divergence, but at the convergence, no nystagmus.
Okay. Okay, actually, I didn't see a case before.
Okay.
Okay, so how you treat them, these type of nystagmus?
By BMR, you should,
BMR.
yes, because here you should shift the null point from the convergence toward the primary position.
Okay, bilateral medial rectal succession. About sensory
Yes.
nystagmus, what is the most common cause you see in sensory nystagmus?
Congenital cataract.
Yes.
Congenital
Okay.
cataract, congenital glaucoma, retinal dystrophy, LEPR, anything, it should affect the preganglionic afferent sensory system of the eye. So if you have anything, corneal opacity, anything, it should interfere with the development of the vision, it will cause a sensory nystagmus, congenital sensory nystagmus.
Okay. Thank you, Dr. Muhammad. I want to ask Dr. Rabia, do you have any experience with these cases of congenital nystagmus from your clinic? And did you deal with any case of these type of congenital nystagmus before? Did you hear me, Dr. Rabia?
Assalamu alaikum, everyone.
Walaikum salam.
Yes, I've seen quite a few patients with nystagmus in my clinic, but I've seen 2 surgeries done by my senior kestenbaum. Just 2 surgeries so far.
Yes. And it's work after surgery, you see the nystagmus decrease?
Yes, it did.
Okay. Thank you, Dr. Rabia. Okay, Dr. Khadija, can you please continue the review?
Review lessons learned. Idiopathic congenital nystagmus is characterized as conjugate, spontaneous, involuntary ocular oscillations that appear within the first 6 months of life. The oscillations are often symmetric and horizontal in 95% of patients. Jerk nystagmus includes a slow horizontal drift of the eyes away from the target, the slow phase, followed by a fast corrective eye movement back towards the target, the fast phase. When the slow phase and the fast phase differ imperceptibly, the nystagmus is described as pendular. The movements may begin in infancy as large, slow oscillations that later mature into smaller amplitude, higher frequency movements, including a jerk movement in lateral gaze. Congenital nystagmus is associated with reduced visual acuity, either as a cause of nystagmus, see case 40, or as a result of unsteady eye movements inhibiting foveal fixation. Associated conditions include ocular manifestations of albinism and optic nerve hypoplasia. Therefore, the ophthalmic examination should include focused efforts to identify steps of these disorders, including iris transillumination defects, optic nerve hypoplasia, and foveal abnormalities, each of which should be listed as pertinent negatives in the physical examination. Other cases of congenital nystagmus may be of genetic origin, with at least one mutation known to cause X-linked congenital nystagmus. Periodic alternating nystagmus is a variant of congenital nystagmus in which the fast phase of the waveform changes direction over a period of 3 to 6 minutes. It is important to recognize these cases before considering surgery, as the head position may change along with the nystagmus waveform. Although periodic alternating nystagmus may be detected by eye movement recordings more often than is clinically observed, office observation of a child over several minutes should be sufficient to detect a change in head position that would require deferring surgery. The most commonly performed surgery for congenital nystagmus is known as the Kestenbaum-Anderson procedure. The procedure is based on performing resections, Kestenbaum's contributions, and recessions, Anderson's contributions, of the horizontal rectus muscles to move the null point of the nystagmus toward primary position. That is, if the head is turned to the left because of a null point in right gaze, the eyes should be moved to the left so that the null point is moved straight ahead. When strabismus coexists with nystagmus, it is possible to combine strabismus surgery with nystagmus surgery by taking the surgical dosage for the strabismus procedure and applying it to the nystagmus procedure in a manner that reduces the total amount of surgery required. For example, if a patient has an esotropia of 25 prism diopters and a left head turn of 45 degrees, the following procedures would be considered. Kestenbaum, surgical numbers given above, including right medial rectus resection of 8.5 mm and right lateral rectus recession of 9.75. Esotropia from Appendix 1, recessed right or left medial rectus muscle 4 mm and resect right lateral rectus muscle 5 mm. Using basic arithmetic, if we combine the planned right medial rectus resection of 8.5 with the right medial rectus recession of 4, we get a net resection of 4.5 mm. If we combine the planned right lateral rectus recession of 9.75 with a resection of 5, we get a net recession of 4.75 mm. For patients with a fixation preference, the strabismus numbers should be applied to the non-fixating eye. While this approach is logical, it is not always correct, and it is essential to use adjustable sutures in this situation, lacking adjustable sutures. It may be best to stage the intervention by operating on strabismus as a second procedure after the head turn is corrected. What would we do if a patient had no head turn at all, but we wanted to reduce the nystagmus amplitude and improve his visual acuity? Beyond convergence surgery, which is my favorite approach, for this situation when it is indicated, there are two approaches, neither of which has gained wide acceptance. The first is known as Dell Osso tenotomy procedure, in which all four rectus muscles are detached from the eyes and then reattached with neither recession nor resection.
Okay, before we continue, let us just make comments here. Yes, Dr. Muhammad, you want to start, make comment, start from like periodic alternating nystagmus. What is the difference between it and congenital nystagmus?
Periodic alternating nystagmus really is a variant of congenital motor nystagmus. Sometimes, okay, it presents with right beating nystagmus for a while of minutes. After that, will dampen slowly, and the eyes without any types of nystagmus for seconds, 10 to 12 seconds. And after that, this patient shows a left beating nystagmus. This is a cycle of nystagmus. So here, I think no intervention can be done because there is no null point here. This is the first thing. The other thing I would share the knowledge about the this insertion of the muscles and reattach these muscles to original insertion. The etiology, or sorry, the philosophy of this procedure is to reduce the proprioception of the muscle, and author here think it works with the nystagmus, and it should decrease the amplitude and frequency of the nystagmus. I agree with the author.
Yes, I hear Dr. Muhammad that the problem that in the nerve supply to this muscle. So when you just recess this muscles or just remove it and reattach it again, this nerve abnormalities, it will be solved. I hear it from one of my teacher. He did
Okay.
Dell's also tenotomy procedure, so he told me that the problem in the connection of these nerve supply to these muscles, so just you remove and reattach, then it will
Yes.
become stable again, the nerve supply.
Mm.
And he told me it's work, especially if there is no any head turn procedure. I don't know if there is no any head tilt or head turn. So I don't know if anyone see it before or he have any idea about it. The Dell's also tenotomy procedure, because always I read it and hear about it. Yes, Dr. Muhammad, do you want to add anything else?
No, another thing about the nystagmus and kestenbaum procedure with a squint is clearly you should combine the amount of the original surgery beside the surgery of the nystagmus. This is clearly.
Here, yes, he just see how much the strabismus and what is the procedure for this head turn according to the stagmus, and he make just the net amount of both of them, and he did it as he mentioned here. I think, as you mentioned, it's clear. Okay. Yes, Dr. Khadija, please continue.
I occasionally offer this to patients if they ask for it, or if I'm already doing strabismus surgery on two muscles, I might perform the tenotomy procedure on the other two horizontal rectus muscles. In my experience with the procedure, some patients report a sustained improvement, but only rarely is there any objective improvement in visual acuity. Another option is to perform large recessions of all four rectus muscles to place the muscles behind the equator of the globe and reduce the availability of the eye muscles to move the eyes. Though it may also work on the same principle as the Osso procedure, the published results of this approach are again equivocal, and the risk of creating a new strabismus is greater than with the Dell Osso procedure. In our patient, the surgical result from a standard horizontal Kestenbaum-Anderson procedure was excellent. It is surprising that eye movements to the right was preserved despite the large surgical dosages. As at first I was concerned that this might have portended an early recurrence of significant head turn, but over 3 years the examination has remained stable.
Okay, I don't know about this high number of recession that he will move the muscle before the equator.
When you have a large number of precision on like medial rectus and lateral rectus in the same eye, the palpebral fissure will be very narrow after the surgery because the new insertion of the muscle.
There is some
uh,
voice, Dr. Muhammad. Just check your mic. It's move a lot. Just to
la-
stabilize it. Yes.
okay, again, when you have a large recession in both medial rectus and lateral rectus in the same eye with large number behind the equator. The palpebral fissure, it should be very, very narrow after the surgery because here the new insertion of the medial rectus and lateral rectus behind the equator and some of the new action like retractor muscle will be appeared. So I don't like these types of surgery.
Okay. So there will be retraction and there will be very narrowing of palpebral fissure. So there is some
Yes.
complications after it. Okay. Uh, a review question. Yes, Dr. Khadija.
Review questions. Name at least 3 pertinent negatives to report when examining a child with congenital nystagmus. The ophthalmic examination should include focused efforts to identify signs of these disorders, including iris transillumination defects, small optic nerves, and abnormal foveal contour. Each of these should be listed as pertinent negatives in the physical examination. 2. Why is it important to rule out periodic alternate interrupting nystagmus, and how is this accomplished? In periodic alternating nystagmus, the head turn may change over the course of 5 minutes as the fast phase of the nystagmus changes. Surgery for head turn may have no effect or may exaggerate one head position while reducing the other, with no net gain for the patient. Periodic alternating nystagmus may be ruled out with a 5 to 10 minute observation to assure that the head position does not change over time. A more sensitive test is extended eye movement recordings, but such a facility is not available in many centers.
I have a
Mhm.
question for you, Dr. Muhammad. In periodic alternating nystagmus, there is two null point or it's one null point?
Uh,
Because here they said it changed. You see, like it's in the right case, then after 5 to 10 minutes, he have changed his position. So I was thinking maybe he have more than one null point. Actually,
I
I'm not
think
sure.
it doesn't depend on the null point. It depends here in the neurological supply to the muscles. I don't know. Really, I don't know.
Okay. Yes, Dr. Khadija, last question.
3. Name 3 contraindications to divergence surgery for nystagmus. Artificial divergence surgery should not be performed if the nystagmus does not damp with convergence, if a patient does not tolerate a trial of base in prisms, or in the setting of poor binocular vision.
Yes. So number one doesn't down with convergence. We shouldn't go for divergence surgery. Number two doesn't tolerate the trial of pace in a prism. And the last one, in the setting of poor binocular vision, you shouldn't do the divergence surgery. Thank you so much, Dr. Khadija. Any question, Dr. Isra Rabia? Anyone have any question?
Yes.
Yes,
Okay.
okay. You go first.
Okay. Because we are discussing the nystagmus, you should mention also that the most form of nystagmus we see in our clinic, which is a latent nystagmus. A latent nystagmus and the other type manifest latent nystagmus. I will share you some details of this nystagmus, this type of nystagmus. This type of nystagmus it discovered at first years of lives, especially with infantile esotropia patients, because here we have a problem in fusion. So when the fusion, I think there is another name for this type of nystagmus. This is a maldevelopment fusion nystagmus. Because of this maldevelopment of fusion, the latent nystagmus appeared. Here we see some features of latent nystagmus. The latent nystagmus doesn't appear unless if you cover one eye. And the another thing, it's a jerk nystagmus. Sometimes it's pendular, but almost of cases it's a jerk nystagmus. The first phase of this nystagmus toward uncovered eye. So when you covering like right eye, the first phase of the nystagmus should be on the left. And also there is another type of this nystagmus, which is a manifested nystagmus. In these patients, the nystagmus appeared manifest. When you covering the one eye, the nystagmus amplitude and the frequency will increase. So this is a very famous form of nystagmus. You should know it.
Thank you so much for this quick revision. Yes, Dr. Rabia, please, you can ask.
So my question is from Dr. Muhammad. As you described that large recessions of horizontal muscle can lead to narrowing of the palpebral fissure. So I believe you're talking about the narrowing of vertical palpebral fissure. How are horizontal muscles are related to the narrowing of vertical palpebral fissure? The reason being vertical palpebral fissure is not connected to the horizontal muscles. So I don't know whether I've taken your comment right or not. Probably you're talking about a recession of the globe after doing large recessions of the horizontal muscles. So kindly correct me if I'm wrong.
Okay, let us revision the insertion of the muscle. You know, the insertion of the recti muscle, it's a front of the equator of the eye, and the insertion of the obliques muscle behind the equator of the eye. When you just imagine with me, if you do tonectomy for an obliques muscle like inferior oblique and superior oblique, can you imagine that the palpebral fissure should be narrow or wider after the procedure? It should be very narrow because of the insertion of these muscles behind the equator of the eye. Some of the action of this muscle like protruded the eye outward, and after you making a tonectomy for this muscle, this action should be
Lead to
should
in
be
ophthalmos. Thigh, it will go inward, you mean?
again. Yes, 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 yes.
Yes.
If you recess the recti muscle behind the equator of the eye, the new action of this muscle, it like a retractor muscle. It should retract the eye inside the globe,
So in
and the
ophthalmos.
palpebral fissure. Yes, the palpebral fissure should be very narrow after the surgery.
So that's basically recession of the globe deep in the orbit, right?
Yes, recession behind the equator.
Yes,
Fine,
behind the
that makes
equator.
sense.
Yes, you are
Yeah,
right.
behind the equator. Yes.
Okay, the last thing I want to show it. So I asked Dr. Muhammad before the lecture how we measure the abnormal head posture. Actually, he showed me this video. This is in American Academy. I will show the link of it. And he show there is an iPhone program. It will help you how exactly you will measure the abnormal head position, how much the degree, 30, 35, 45. So there is program on the iPhone. Also, there is other type of measurement. One of them, they call it goniometer, and the other one, it's arm tool measurement. I saw it also in the box. I read about it, but I didn't use it before. So these are, I think, three tests for how to measure the angle of abnormal head posture, and it will help you to decide which surgery you will do. Before we close, anyone have any question? Okay, thank you all. Thank you so much. I will stop recording now.
Thank you, Dr. Abdulrahman.